You are tuned into the Dr. Tyna Show with Dr. Tyna Moore. For more, visit drtyna.com. On this episode of the Dr. Tyna Show, I get to sit down with my good friend, Dr. Laura Neville. Dr. Laura is a naturopathic physician. We go way back. She is also a type 1 diabetic. And I often get asked by you guys, what about type 1 diabetics? What do we do when it comes to metabolic health, metabolic optimization? And at the end of the day, the rules are the same. But I'm going to let Dr. Laura explain it to you as only she can, as somebody who has been dealing with this condition since she was a child, and she has navigated it beautifully. You're in for a real treat. If you are the mama of a type 1 diabetic, if you have type 1 diabetes yourself, if you are a type 1 diabetic walking into the menopausal or middle age years, you're going to want to listen to this. And if you're not, I encourage you to listen to it anyway, because it is chock full of pearls, all about metabolic health, all the things you guys asked me. We talk about it in this episode. So without further ado, let's jump in. Dr. Laura Neville, thank you so much for coming on the show today. I'm so excited to have you. We are old friends, and you are a fellow naturopathic doctor colleague, and you are also a type 1 diabetic. And I keep getting asked from all the type 1 diabetic folks in my audience to bring an expert on, and I could not think of anyone better than yourself. So welcome to the show.
Thank you so much. It's such an honor to be here.
Yeah, I'm so excited. We haven't talked in a long time, but we go way back, and I know we agree on a lot of things. And so I think this will be a fun conversation because, no, I shouldn't say agree, like we both understand the truths of metabolic health. So here's my dilemma, and this is what I hope we can solve today. We were talking a little bit offline. Back in the day, I would refer to everybody as, a person with diabetes, or I would refer to the condition of diabetes, and the folks that were dealing with type 1 diabetes would always say, what about us? We're different. This is distinct and separate. And it is. And I'll let you explain the differences in a minute. So then I started talking about metabolic health in reference to type 2 diabetes, and yet still the type 1 diabetic folks would say, but what about us? As if potentially the rules were different for them when it came to metabolic health. And so I'm hoping we can put that whole thing to bed today on the show and get the facts straight for folks, because I know there's a lot here to unpack, and I'm going to let you just launch in. So you have a really interesting backstory, and if you would be so awesome to share a little bit about it, I think it would really help the audience understand where you're coming from.
Yeah, absolutely. So I was diagnosed with type 1 diabetes. It was probably like 2 weeks before my 7th birthday. So as many of you know out there, you can have children where this is diagnosed very, very early. They can be infants. That's, I think, one of the hardest times to be diagnosed, but it can happen throughout the lifespan. We're seeing older and older individuals diagnosed with type 1, but back in my day, in 1989, I was diagnosed with type 1. So I was in 2nd grade. There wasn't a lot of other type 1s at that time. I was the only one that I knew of. So I think that really shaped my whole life, in many ways. And it made me start to question, because as you all will know, if you have family members or children, or you're type 1 yourself, there's so many questions that we have unanswered. And the term diabetes gets used quite a lot. I think, it's unfortunate that type 2 and type 1 share that same name, because they do get lumped together. They are quite different and distinct pathologies, although there is definitely crossover within the two. But that it shaped the way I thought about health on a daily basis. And it really made me very interested in alternative health, because I wasn't finding the answers that I was seeking as a type 1 diabetic, and the reasons, how it develops, why it develops, and how to maintain it throughout and control it well throughout the lifespan. So it was in my early 20s, I saw a naturopathic physician as a patient myself. I was living in Southern California and, eating all the rice and all the carbs, and I didn't know left from right, and saw a naturopathic physician who very succinctly in the first visit shared with me about the importance of protein and adding protein to carbohydrate when you're eating complex carbohydrates, and exercising. And, she also did a hormone test on me, which is why I'm so passionate about that also. And that just, I mean, hands down, that changed the course of my entire life. Like type 1 diabetes became much easier to manage. And I started to understand the deeper aspects of it other than just take insulin and count carbohydrates. You know, it became much more interesting to me. And I had a lot more control and a lot more power, like for myself that I could use. So that I was like, hands down, I need to do what this woman does. And so went to naturopathic school, and that's why I'm here. So the rest is history, but that's how it got started.
Yeah. So you are an expert on the subject. Absolutely. I mean, I can't think of anyone better to refer to whenever I have questions or need to know answers. You always come top of mind. And you're also a hormone expert, which I think fits in beautifully and is so critical. It's and we can talk some about that, how it interplays with type 1 diabetes. You shared with me offline, I shared with you a frustration that I have whenever I talk about diabetes as a general term. You're absolutely right. They are almost two very distinct and unique conditions. The mamas of the type 1 kids come at me hard, and they are a fervent group. And I didn't understand. I was like, what the hell? Like, I can't imagine what would make this group militant. Like they come at me, and you shared something really eye-opening a moment ago. Would you share that with the audience?
Yeah. And I say this with all love because I am in this group. We are type 1s or caregivers of type 1s. We're burned out. This is a disease that takes a level of management that most people can only imagine on a daily basis to stay alive. It's kind of like walking a tightrope, right? And especially, I think I have a lot of compassion for it's the mamas of the type 1s, because it is so hard to control. There's so many variables to blood glucose, and you're doing that in your young child. It's a very scary thing. They have to be like scientists, brilliant scientists, whether they want to be or not, immediately the day that child is diagnosed. There's a lot to manage. So that's part of it. And I think part of it is just that there is a kind of lumping effect where we're talking about metabolic problems and insulin resistance and maybe eating poorly over a span of maybe decades for type 2s. And type 1s get really like, I eat so diligently. I follow, like, my lifestyle is like this wide where, I get wiggle room. And so it feels offensive to kind of be lumped in with maybe someone who wasn't, really doing their due diligence on their diet and lifestyle. So that's probably where that comes from. There certainly is metabolic health that we need to talk about in type 1 that doesn't get spoken about, but it's still, I think, immediately like the gut punch is a little offensive because it's such a difficult disease to manage. So I think that's mostly where that comes from.
Totally fair. Hadn't even thought of that. I mean, I realize it's a drain on the mother to have to try to manage. And I can't even imagine. There are so many variables. When I wear my CGM, it's crazy what lack of sleep and extra stress will do to me. It's just crazy how it sets my blood sugar awry. So I totally get that part. But when you said the part about how they didn't want to get lumped in with type 2 diabetics, it totally made sense. And for all the type 2 diabetics out there, I mean, if you guys have listened to me for any amount of time, I have a great deal of empathy for that category of folks, but like that is a lifestyle induced process for the most part. And so, we can all end up a little insulin resistant for various reasons, but to really get to type 2 diabetes, like that doesn't happen by accident. Unfortunately it does, but people don't know what's happening because their doctors aren't doing their due diligence to track their patients for metabolic health. But yeah, you're right. You arrive there after usually decades of neglect on the body. So totally like aha moment. So I apologize to all the type 1 mamas if I've clapped back at you for coming at me online. This is my formal apology because I get it. So you said something too that this comes on rather abruptly in a child, and it can happen when they're babies. It can happen like you when you were in second grade. I mean, it's like one day everything's fine and the next day it's not so fine. Is that usually how this goes down?
Yeah, it can happen very quickly. It can happen so the problem is the symptoms are only really present when the beta cells of the pancreas have the majority of them have been destroyed already. So this is somewhat of a silent process, probably over the course of a couple years, quite honestly, but you really don't see any symptoms until the very end of that tissue destruction. So unfortunately, it can look very similar to just the flu or a fatigue, or it can come on after, like we're seeing a lot after COVID infections. It can happen seemingly abruptly, to where the symptoms really are only there for a couple of weeks, and then the child or the person can go into a coma.
Yeah. Yeah. Mm-hmm. And yeah, I can imagine that would be terrifying to deal with your child. It's happening in dogs at high rates and cats. Like it's happening across the board. So there's definitely a problem. Something is going on in the environment. I do want to say it's very exciting. The data I'm finding on GLP-1s and their impact on protecting the beta cells and regenerating the beta cells in some cases is freaking amazing. And I'm so excited about it because I think caught early, this can be such a potent tool, adjunctive tool in the toolbox. And I think a lot of doctors aren't thinking about using it because they're like, well, the standard dosing is so damn high and so aggressive for people. And this is where I'm really trying to ring the bell on this microdosing strategy of just fractions of the starting dose compounded in a small child, like could be the difference between them maintaining beta cell function or not, So I don't know. What are your thoughts on
absolutely. Yeah, it's very exciting. I think the key part there is caught early, which is a little tricky, but yes, fasting mimicking diets too in those caught early and GLP-1s. I mean, yeah, it's very exciting. And I agree that microdosing, because it's easy to kind of cause pretty massive hypoglycemia right out of the gates, or even DKA, where there's, high doses of these GLP-1 agonists, and then you have vomiting or nausea. And then there's a whole, so many different factors go into blood glucose regulation. So that right there opens a can of worms, and you can get DKA and things like that. So I think, yes, the microdosing is really exciting, and I can't wait to see what that develops in the future. But I agree.
Yeah. And I want to say this for the record, because for some reason I keep 99% of the time when a follower comes to me or a doctor comes to me and says either I'm microdosing in my clinic now, or I called a pharmacy and they told me how to microdose, or a follower says I went to see Dr. So-and-so and she microdosed me. They're doing the starting dose, the standard starting dose. And I'm talking about fractions of that, you guys. And I really want to make this clear, because I do not understand how this keeps getting confused. I would never in a million years start somebody at the standard starting dose if I thought that would be too much. And then these folks are saying, I'm on the lowest dose and I'm so sick and I've been in bed for a week vomiting. And I'm like, you're being overdosed. This is not rocket science. And what that dose is totally dependent on the individual, right? I can talk strategy inside my course, but you're a naturopathic doctor and hormones, so you know what I'm talking about. This is just meeting the patient where they're at, figuring out what they need, right? And it's completely different for everyone. Some people, the standard starting dose might be what they need. And for many others, especially the more metabolically optimized someone is, the more muscle mass they have, the less fat they have, they're probably going to need a fraction of that. It could be a 1/10 of that. It could be a 1/5 of that. It depends, So I only share that because I do not want any doctors out there thinking, I'm going to give a standard starting dose of semaglutide to a child. That's not a good idea. So anyway, okay, I digress. So let's talk about metabolic health. I talk a lot about strength training, keeping your refined carbohydrates low, making sure you're getting adequate movement throughout your day, all to balance the blood sugars. And the type 1 diabetics always say, well, what about us? What do we need to do? And I'm like, same.
Same. Yeah.
So can you dive into that, please?
Yeah. So I think all type 1s understand that exercise will lower their blood glucose, right? Skeletal muscle it doesn't require insulin for the glucose to drop. So it is the only thing that we have available on this planet at this time, other than taking an insulin injection, that is going to regulate blood glucose. So it's that important. It is the largest tissue mass responsible for glucose control. So after you get out of the hospital, or your child gets out of the hospital, and you learn how to, dose insulin injection wise, whether that's a pump or whatever, the very second thing after that that's going to keep you alive is your skeletal muscle. So keeping that as healthy as possible, which means using it and squeezing it, is going to be your best treatment for type 1 diabetes that exists, or probably will ever exist. There can be, adjunctive therapies and supplements and, all of those things, but that's really the key. It's that skeletal muscle that's so important. And we do have damage to the mitochondria and the muscle in diabetes, especially after the age of 40. So it becomes even more important to keep that muscle as healthy as possible and use it and squeeze it.
Amen. So. And can you explain why that is? Talk about the insulin dependent pathways and the insulin independent pathways of getting GLUT4 receptors to the membrane.
Yeah. So insulin can be floating around, or glucose can be floating around in the bloodstream. It cannot get into the cell and be utilized and used for energy unless there's a receptor to allow it in. One of those is an insulin receptor. So insulin will allow that to come in. There's also non-insulin receptors that allow that to come in. So those are, there's only a couple different ways that it can get in. And if it doesn't have one of those, it's going to be floating around in the bloodstream, rotting everything, basically damaging things, and not able to be utilized for energy. So you feel very fatigued, gaining weight, no energy. That it's almost like you didn't eat at all. The glucose is just sitting in the bloodstream, not doing anything.
Yes. And when you it's the actual act of contracting the muscle, like you said, squeezing the muscle, contracting the muscle gets that GLUT4 receptor up to receive that glucose into the cell. And it's independent of insulin. I think the biggest fallacy in the low carb world and the keto world and in the type 2 world, and I'm sure in the type 1, everybody's so hyper focused on insulin. And I know that's what I talk about mostly online because it's the easiest thing for people to wrap their heads around so I can get their attention. But to me, that's like 1/3 of the solution of getting glucose into the cell. The other ways, there's different pathways that we have to ignite, and fasting will do it. Exercise will do it. Muscle contractions will do it. GLP-1s will do it. There's different pathways, the AMPK pathway, the SIRT1 pathway. Like we have to activate these pathways to make our cells a glucose sink, right? Like we need to build the sink. So I always think of it like, I just want the biggest sink available. And so that's just one way. Like it would be like if there were 4 different ways to start your car engine and we were always just hyper relying on one. And so the folks that are like, I'm just going to go super low carb and that's my solution. And you watch them shrink, but they never do any exercise and they never, ever do any strength training. And I'm like, good luck with that. It's going to last you a little while. And then you're going to balloon back into this terrible, hyperglycemia.
Yeah. Fascinating there. And SIRT1, I think, is so interesting. There was a family that they had a genetic SIRT1 deficiency, and I think there were 5 children in that family. 4 of them had type 1 diabetes, and one of them had ulcerative colitis or something like that. But it shows you how important, those receptors are for getting glucose in.
Yes.
So
this is why I say that strength training is non-negotiable. I don't care if people like it. I don't care if they're bored. I get that all the time from I don't like it. I don't want to. Is there something else I could do? Can I do Pilates instead? And I'm like, Pilates is awesome. I do it frequently, but it's not the same as actually lifting heavy things and picking them up and putting them down and trying to build that sink of skeletal muscle, right? So we can dump that glucose out of the blood and get it in use and get our mitochondria revved up, because all these pathways we just talked about rev the mitochondria. Like that's how you get your mitochondria working optimally. Without that, I don't know. It's like I'm watching people do this roundabout, comfortable version of trying to optimize their health and they're like, they'll hyper fixate on what they put in their mouth, but they won't walk into the gym. And I'm like, no.
Yeah. Yeah. And it's especially important for the type 1s because there's muscle damage that happens with time. It's just the nature of the condition. And so you have to do that even more judiciously than the person next to you, because myopathy is happening. It's muscle damage and it's induced by diabetes. So doing that strength training, they have done studies on this. You make up for some of that and you live longer, you live healthier, and you don't have complications, which is hands down what every type 1 diabetic wants to hear. They don't we've had enough fear-based stuff put in our heads, you're going to lose your feet, you're going to go blind. You don't want to hear that. Just go to the gym and then you can ignore all of that.
I'm pretty sure people could just go to the gym and ignore so much.
Yeah.
They don't want to hear it though. If I ever dare say anything like that, people get so mad at me because they think that I'm discounting everything else. And I'm certainly not. This is just probably one of the most powerful tools. You lectured at A4M a couple years ago and I was in the audience, front and center, yes.
Yeah.
I just wanted to I just wanted to ring
a
cowbell every time you put up a slide because you kept going into this skeletal muscle piece. And I was like, guys, we gotta, and it's just amazing to look at all the doctors at A4M and so few of them actually have good skeletal muscle, And I'm like, what is everybody missing the boat here? This is the piece. Can you talk about the myopathy of type 1 and just a little bit more about how and why that happens?
Yeah. So, there's several factors, but it's bottom line, it's mitochondrial damage. The muscle gets damaged so that it's not as strong. You have less of it. It doesn't take up as much mass. And there's reactive oxygen species from high blood sugar that kind of just eats away and damages the muscle. They call that myopathy. And the diabetic version is considered quote unquote mild if you're looking at diseases that have myopathy included in them. But you can reverse. The important part is with this type of myopathy, it can be almost entirely, if not the majority of it, reversed. So, and that's, squeezing your muscle. It keeps the mitochondrial cells healthy and organelles healthy within that muscle. So it has to be done. It's just as important as giving insulin, in my opinion.
Amen. I hear you. I mean, I'm not a type 1 diabetic, but for everything else out there, if this is just as important, I see so many female doctors online right now. There's a big movement in the space, which I'm very excited about. And I applaud them and I follow them all and I cheer them on, but they're really often, estrogen's always the big conversation, right? And making sure that menopausal women have access to hormone replacement therapy. And I'm 100% for that. However, some of them do mention muscle and strength training. Dr. Mary Claire for sure talks about it, but there's a lot of others who just really don't, and they're not driving it home. And I'm like, you guys, this is because the reason I'm saying this is because this takes me into maybe the older woman. You're not very old, but you're going to be in menopause one of these days here. And as that estrogen drops, we become more insulin resistant and we become less able to balance our blood sugars. And I can imagine this is a treacherous time, I don't mean to put fear language in there, but a more treacherous time for the type 1 diabetic woman would.
Yeah, absolutely. And there's been studies looking at estrogen, specifically in type 1s. Estrogen, usually you give that and it dilates the blood vessel. In a type 1 diabetic blood vessel, and I'm saying that assuming this is an unhealthy blood vessel that, they haven't been taking care of their blood sugars and eating well and things like that, it shrinks it. It constricts the blood vessel. So it's the very opposite thing is happening with estrogen in an unhealthy type 1. So to me, that means hormone replacement I can't sing its praises enough, but I also think you're potentially doing sometimes more harm than good if you are just giving estrogen replacement at menopause and you're not giving the antioxidants, resveratrol, increasing SIRT1, doing the sauna and squeezing the muscle so there's enough muscle mass to be anti-inflammatory and control that blood sugar better. You potentially could be causing vasoconstriction of the blood vessels, which is the opposite of what you want.
Is that true for pretty much anybody who's in a metabolically compromised state and is unhealthy?
Yeah, I would say so. Absolutely. I think type 1s are just the cornerstone of the epitome of that, with blood vessel unhealthiness if they're not taking care of themselves. So it's probably just showing you the average person on steroids, not literally on steroids. It's a bad word to use here, but you know what I mean? Like a magnifying glass on that.
I so agree with you. I often share out with my audience that when they ask, and I talk about this inside my course at length, I do not condone the use of estrogen in a metabolically compromised individual who has particularly a lot of inflammatory body fat to lose, because it just really mucks things up when you put it in a system like that. And you don't know what pathways it's going to go down, and you don't know what it's going to do to the vasculature. And it just really gets confusing. And so your average middle-aged woman, diabetic or not, type 2 or type 1, is probably sitting in that category. And then we're throwing hormones at it saying no hormones are safe. And it's like, yeah, they're totally safe in a metabolically healthy person. And just like GLP-1s are, this is where I think GLP-1s are beautiful, because you can start to reverse that insulin resistance and that metabolic dysfunction pretty quickly in someone, and then sort of clean up the landscape to add in the hormones if need be. And then the hormones make the GLP-1s work better. So there's utility there, in using it carefully in the right population, because they need the estrogen and as they're getting older, and yet we can't always use it or expect it to do what we want it to do in a healthy, safe way if the person's sitting there in like a really deconditioned, metabolically compromised state. Okay, that takes me to my next thought. I'm going somewhere with this. Years of using insulin exogenously, right? You're injecting insulin, whether it's a pump or you're doing it with a needle and syringe. What happens to someone who's not taking really good care of themselves in that process versus someone who does, like yourself?
Yeah. Well, insulin, if we remember, it's anabolic. So the more insulin you take, the more mass you are going to take up. So if you are not tracking that well and not, here's, I think, the biggest problem. Back in my day, there was insulin types called regular and NPH. And when you gave those types, you had to eat a very succinct diet. It was like 6 small meals a day. I literally weighed my food. It was very regimented. And I really didn't go off track of that, because you can't. The insulin tells you what you can eat. The short acting insulins that have come out on the market, love them. Thank goodness they've given us all some more freedom. But with that freedom has kind of been this marketing push of, hey, you can eat whatever you want. You just count the carbs and you take the amount of insulin that you need for that carbohydrate. It's called carbohydrate counting. And it's given us, unfortunately, free reign. And it's like letting the gorilla out of the cage. Any type 1 that's been kind of, pigeonholed to very strict eating, you give them that freedom and it's accidentally going to cause overconsumption of carbohydrate. And then you're going to be using more insulin and you just using as much as you need, right? So too much insulin, it's too anabolic. You gain inflammatory fat. And if there's no exercise being done to counteract that or drop the insulin dose overall, it can cause issues. You see a lot of type 1s with kind of a belly pooch that happens with taking too much exogenous insulin for their body requirements. So that happens. There's also, I think you and I had this conversation a long time ago, that there's, they add phenol to insulin as a stabilizer so that, there isn't bacterial growth within those bottles. But phenol is not, and not a healthy thing to be injecting into your body all the time. So unfortunately, the more insulin you take, the more phenol you get. There's irritation and scar tissue at the injection site. A lot of these things lead to very poor responses to insulin injections. There's, like I said, that scar tissue can build up and it causes a lot of problems with insulin absorption. So you have that. I mean, as if there weren't enough factors, throw that in there and there's some complications from that.
So taking care of oneself and lifting weights and doing all the things to optimize metabolic health that we all talk about is going to allow potentially the individual to use less insulin. So they are injecting less often. They are having less of an anabolic load. And now this, insulin's awesome when after you strength train, your insulin should go up, like not maybe in a type 1 diabetic, but in someone with, adequate pancreatic function, you should get an insulin surge because it is anabolic and you utilize it at that time to build muscle. So there's utility in it. Insulin's good for us when we need it. We just don't want to be bathing in it, anybody. So that's, right. I think, such a really, something happens too, I've seen in patients that don't take good care of themselves and just sort of use that insulin backup to counteract their crappy diets. Their skin gets weird. Like there's a weird turgor to it. Like everything just starts to get morphs into a sort of a weird textural difference. And it's like, oh, this is not good. And I see that too, though, with folks who are just swimming in insulin resistance, the folks outside of the type 1. They are, I don't want to say normal people. I don't know what the term is. Non-type 1s. Yeah. Everyone else. Yeah. They end up, let's talk about the difference between type 1 and type 2. But yeah, they get the same kind of like dysmorphic, because my background was in regenerative injection. So I touched these people. Their tissues were very different. When you are cranking insulin, whether it's because your body is producing too much, because you're eating shittily, or because you're type 1 and you're having to inject a lot of it and you're not really taking good care of yourself, so you're maybe having too much insulin. Either way, it's not good. The tissues get flaccid and they don't hold well. And I can imagine that's doing terrible things to your joints and to the rest of your tissues. So, and there's definitely a component of cortisol in there too. I don't know if you see that on labs, but anyway, first, let's back up because I'm going on a rant. What's the difference between type 1 and type 2, just for the audience in case they don't know?
Yeah, so type 2 we consider metabolic syndrome that moves into pre-diabetes, then into diabetes. So there's an insulin, the pancreas, the beta cells within the pancreas are secreting insulin, but the cells are not responding as well to that insulin as it should. So what happens is the pancreas will secrete more and more insulin. You have a high insulin levels, but it's not helping at the cellular site. The glucose isn't going into the cell. You test the blood sugar. It's not getting into the cell. It's just staying around in the serum. So you can read that on a blood sugar reading. There's high glucose. With type 1, there's a somewhat silent autoimmune process that's happening very deep in those beta cells. The immune system is destroying the beta cells. They stop functioning. There is no longer insulin produced by the pancreas at all. And so that's why the blood glucose, it's somewhat, it's a greater spike, a greater degree of hyperglycemia because there's just zero insulin there at all.
And that's why it used to be called juvenile, because it
used to be called juvenile because only children would develop this autoimmune degree. Now we have to not call it that because juveniles can develop type 2 nowadays. That didn't used to happen. And adults can develop type 1, which also didn't used to be very common at all.
What do you think the shift of that is? Is it just our modern life or?
Yeah, I think environmental toxicity is massive in type 1s that we haven't fully uncovered. I think you certainly have genetics that predispose you to being, sensitive to that development. But I think there's an environmental aspect. I think there's so much environmental toxicity that our immune system just goes haywire. It's just too much on the immune system, whether that's a viral load, allergies, poor processed foods, like this all kind of adds up to a perfect storm. And definitely the children, just getting their hands on processed foods and eating that for the majority of their lives. That's where you're seeing the type 2 in children.
Yes. It's been really weird to watch in my lifetime because I'm 50. And I remember when I was a kid, my 8-year-old cousin developed type 1 and he was a really active kid. You were a really active kid when this onset. So yeah, he was super active, super good athlete. And I remember being shocked. And at the same time, I had an uncle with type 2. And so I actually went digging because I think I was destined to be a doctor since I was little. And I went digging to find out the difference because I was like, how do they both have the same condition? That can't be right. Because my uncle had a big old belly and he drank too much and he smoked and he was not a Midwestern dude, not healthy, you know? Sure. And I think he died of a heart attack. And I don't think my cousin fared well. I haven't kept up with him. I don't know how that ended, but and then I had a niece, other side of the family, and she had a lot of issues when she was born, and she ended up with type 1. It's just insidious. And like one day they were fine and the next day they weren't. And I can imagine that's really difficult for parents. Like you said, the mom has to become, or the dad has to become a scientist overnight, because I guess what I'm trying to drive home here is it's not even just about the figuring out your insulin dose, matching it up with your carbohydrates. It's understanding metabolic health, which I think you do such a good job of teaching. When I see you give lectures, you're like, we have to dial this piece in also.
Mm-hmm. Yeah.
What would you say to the middle-aged adult, man or woman, who's, maybe in our age cohort, and they have done a great job like you, and they've kind of figured out the journey? What does moving into menopause and andropause look like for them? And are you a fan of using hormones? Like, talk about that.
Yeah, I am a big fan of using hormones, although, again, I have pause, and I'm using usually conservative approaches and making sure cardiovascular health looks good before we start on something like that. You have to be exercising. You have to be eating whole foods. If you're eating processed foods and you're not moving your body, it's not a good idea to be using hormone replacement. I think it's life-saving a lot of times to use it, but you can't just use that and expect everything to go okay. I think type 1s oftentimes suffer from hormonal imbalances even more than the average person. There's so many young people with PCOS and type 1 diabetes. Like, the correlation there is huge because it's overconsumption of carbohydrate and lack of skeletal muscle that's causing PCOS. And so if you have hormonal imbalances in PMS or PMDD or PCOS, and then you're moving through perimenopause and menopause, it's going to be a bumpy ride. It's not going to be fun at all. It's going to be harder than the person next to you that doesn't have type 1 diabetes to deal with also.
Can you repeat what you just said about PCOS and what causes it so people really understand this?
Yeah. So overconsumption of carbohydrates. I think of PCOS in a young person as basically early metabolic syndrome. It's we're eating too many carbohydrates and you're not moving the skeletal muscle enough. And for reasons that still are a little unknown, when that happens and there's blood sugar dysregulation and even mild insulin resistance, the ovaries will overproduce testosterone and DHEA. And that is classic PCOS. You don't have to have cysts on your ovaries. That's not always part of that, but the degree of type 1 diabetes with PCOS is like 5-fold to the average population. So that is what that's about. And if you have hormonal problems in PCOS, it's going to make your transition to perimenopause and menopause more difficult, more challenging.
Yes. And 9 times out of 10, it's what you said. It's metabolic dysfunction. That's at the root core. Because that's the other question I get when I talk about things online. People say, what about PCOS? And I'm like, it's exactly same. Same rules. Everything goes back to the same rules. Everybody has to play by the same rules. We're human beings. We all abide by the same natural laws of health, right? So, I would add, what you mentioned about the just insurmountable amount of injections that children get at a very young age, and then toxicity. I think that contributes to PCOS as well. And so you've got just kind of it's the mixed bag. And the way I explain it to folks is it just depends on how it decides to present for you, right? We're in this toxic soup of a planet, and everyone's toxic bucket burden is different. And so some of us overflow when we're young. I was hit by a bunch of stuff when I was young, the autoimmune that nobody could figure out. It didn't have a name. Nobody knew what was wrong with me. And so that went on for years and decades before getting that sorted out. And I had almost wished I had something that somebody could have put a finger on and said, it's this.
Right.
But it wasn't until I met my naturopathic mentor who was like, you have to keep your waist circumference in check. You have to exercise all the time. Like every day you have to sweat a little bit, whether that's in the sauna or that's exercise, sweating, whatever. You have to move and build muscle, forget all the chronic cardio, like quit doing steady state cardio and just build muscle. And this was like way back in the early 90s. It was groundbreaking information. He told me to stay away. There was no paleo diet then. There was no carnivore diet. There's none of that. He just said, stop eating white carbs. Like just stop it. It's not good for you. It's not going to help your hormones. And lo and behold, when I listened to him finally, it took a while, but when I finally adopted what he said and started doing it decades later, everything got much better. So he was onto it, he was onto it early, but he really drove home the waist circumference thing. I didn't understand that for years. I thought it was a vanity thing. And finally he explained it. He's like, no, that's your gauge for your metabolic health, your muscle and your waist circumference. And he also taught me, if someone's not lifting weights, and I say this when patients would walk in the door, my first 3 questions really were like, are you lifting weights regularly? No. Usually the answer is no. I could tell what their waist circumference was or that it was elevated. And if they had elevated blood pressure when my assistant took it, when they entered the office, I knew they had metabolic dysfunction straight up. And I had type 1 diabetics in my practice, and they would same thing, and they wanted different rules. And I was like, there's not. You have to follow the same rules. We all have to have the glucose sink built and functioning, right?
Yeah, it's a really good point. I mean, I think the type 1s, it's a very unique chronic illness. And I think a lot of type 1s really feel like no one understands unless you have it, which is partially true. So then we get into this place where we're like, well, it's like them against us. And we're in this, like on this island, and part of that is true. So I understand that, but it's enlightening to remember as a type 1 that you could technically get type 2 also. Like you'd probably pass away before that, but you can have type 1 and have early metabolic syndrome moving towards type 2. Like that, mind blown. We don't want that, just stick with your type 1. You've got enough to deal with. Don't go into the world of pre-diabetes and early type 2 diabetes.
Oh my gosh. That is so true. It's so true, right? I mean, they're walking around in middle age also with a ton of metabolic dysfunction. And often the patients I would see wanted to blame their type 1. And I was like, no, dude, it's your ice cream bowl every night or all the rice you're eating, a whopping dose of rice you're eating with every every dinner. Right. It's like somebody should watch my husband put rice away. That's been my biggest difficulty in this marriage of like, he's been so like, he's totally converted to my way. I was just talking to another gal who's in the functional medicine space, and she's 9 months in with a guy, and she's like, I really hope this one works out because I am so tired of teaching these guys. And I'm like, it's so true, right? Like you have to bring them into our cult because we're right, but it's a lot of education and the rice. That's the one thing where I'm like, dude, you don't need the giant Pyrex bowl of rice to go to work with. Like, what are you going to put? There's no amount of protein you could put on that to offset the carb load you're just consumed. But anyway, and then to add to that, type 2s can end up blowing out their pancreas and destroying it and becoming insulin dependent.
Yeah. That is a real thing as well. And type 2s will fight me. I see a lot of type 2s in my practice, and just that they do not want to go on insulin. They don't want to have to start taking insulin injections. It's like, well, you get so many chances before your pancreas just can't keep up. And it's been working so hard for so long. So if you don't give it that break, you got to go on insulin injections. And I will tell you, they're not fun. It doesn't matter how long you've had type 1. It's not fun to do.
No, I had a patient once who his dad ended up as a type 2 who ended up insulin dependent and real heavy set guy. And this guy was real heavy set. And I was telling him, I'm like, we had him going in the right direction for a minute, and then he just didn't want to keep up with the lifestyle. Again, this is like looking back, I'm like, God, I wish I had GLP-1s at my disposal. I wish I, had semaglutide for this guy or tirzepatide. It would have been such a game changer because he really had just an enormous appetite. And as somebody who have never had a huge appetite, I cannot even understand what that feels like. I've only had that when I was pregnant. And it's like, I could only imagine what waking up and like thinking about food immediately. It's just a different wiring of the brain. It's a different set of neurotransmitters up there. And this is where when people say, oh, obesity is a choice. And I'm like, that's really short-sighted. Like 1980 called, they want their ignorant whatever back. Cause that ain't it. Like there's a lot more going into this. Anyway, he was backsliding. His lifestyle habits were starting to shift back to, he's drinking too much and he was gaining the weight back. And I said, look, buddy, your labs are not looking so great now. And he's like, oh, I guess I'm just going to have to go on insulin like my dad. Like he really believed this was the journey and the fate. Yeah. Like he thought this was a sure fate for him. And I was like, what? No, like you have an enormous amount of control over what happens here, as a type 2 I'm talking about. I was like, this is, well, even as a type 1, you have an enormous amount of control over so many variables. And I share this to empower, not ever to make someone feel shamed, because I, as someone who's had really devastating autoimmune conditions inflict me, I understand wholeheartedly that we either walk ourselves further down that path through our lifestyle, or we say, not today. And we make conscious choices about what we put in our mouth and how we move our body, whether we want to or not. We don't have a choice. Like autoimmune disease keeps you honest. Yes. Right?
It keeps you humble. You have to respect that autoimmune condition. I find that over and over in type 1s. A lot of times we get to like pretend like, it's not there for a hot second, but you only get to do that for a very short amount of time before it humbles you and knocks you to the ground.
Yeah. So. I remember once we were, right before the world went into lockdown, you and I were at a party and we had a cocktail and I was like, do you want another one? And you were like, no, because you're like, no, I've got to manage my insulin. Yeah. And I was like, oh yeah, noted. I mean, that's a quick way to not indulge, imbibe in more alcohol, right?
Totally. It keeps you real, like on a trajectory. Yes.
Speaking of the world locking down, let's talk about what viruses do to the pancreas, because I think that might be another factor also, for sure. I'm sure that's a factor with children. Like, who knows? Maybe you had a really bad virus when you were in second grade, and then, and kids don't always process a virus the way adults do. So they may not have symptoms nearly as hardcore. And then the next thing you know, you are plunged into some kind of autoimmune process like type 1. So what are your thoughts on that?
Yeah. So, without boring people of like really intense biochemistry, what can happen with viruses is there's something called molecular mimicry, where the very virus or the pieces of the virus that the immune system is targeting, the immune system can become a little bit over rampant and decide that the tissue, whatever that may be, whether that's the thyroid or the beta cells in the pancreas or the colon in, say, ulcerative colitis, looks similar enough molecularly to what it's trying to fight that it then causes the immune system to kind of go and quote unquote attack that tissue. And eventually, over time, enough tissue gets destroyed to where you start to have symptoms.
Yeah.
So that's it in a nutshell.
And COVID definitely has been linked to type 1, right? Like that's a thing.
Yeah.
That's happening.
Yeah. I've seen it. I've spoken to many patients who that's how they developed it, was right after the year 2020, and they had COVID, and shortly after that developed type 1 diabetes. So It's certainly there. It's probably the straw, the last straw, right, on the road there. You already have maybe your toxic load or your bucket somewhat full, and then that's what's going to tip it over the edge.
I think that COVID did that for a lot of things. I think it plunged a lot of people into hypothyroidism, or into, it just sent them right over the edge on their adrenal health, or sent them over the edge of menopause. I think a lot of women were sitting on the edge of menopause and got thrust into it. It's like if you're standing on the edge of the cliff, COVID will shove you right off it. And so we're seeing a lot of this supposed long COVID, and not to discount it, because I understand post-viral syndrome very well. However, really, at the end of the day, post-viral, I mean, I even think I saw a study recently. I shared it with another naturopathic doctor, and she's like, in modern news that naturopathic medicine has known for decades, they determined that COVID was, an imbalance. It looks very autoimmune, an imbalance of the immune system, and an issue with cortisol. And I was like, yeah, no shit. How about some adrenal fatigue and some hormonal imbalance? Yeah, and some autoimmune. Like that's That's what viruses do. All viruses can do that though. Like it's not just this one, right? So a bad round of the flu, a bad, Epstein-Barr, cytomegalovirus, something like that. This
is not new. This has been going on, for a long, long time. They've even, I think Kawasaki B is probably high on the list of what they think causes or is the impetus for that last straw for type 1. But yeah, a lot of viruses.
And viruses cause cancer too. There's oncogenic viruses. There's so much to this that people don't understand, and they want it to be one thing, and it never is one thing, right? It's a multitude.
I know.
How would you categorize some of these patients that you saw go into type 1 after getting sick with a virus? Were they healthy going in, generally speaking?
Nowadays, everyone's always got some stuff, that you could see leading up and going, oh, well, duh, and I don't mean to be callous about that, but we live, like you said, in a toxic soup. And so I can see components of risk factors in every single person. And I think that means that, not to freak people out, but every single person walking around has risk factors for a lot of things, including type 1 diabetes. I think it's a perfect storm that happens. So yeah, I don't think any of them were perfectly healthy. I could always point to something that was probably a large factor in the development.
I think the one thing that I saw in clinic that would determine how somebody fared through, going through and coming out the other side of anything, whether it be a traumatic car accident, a traumatic virus illness, a traumatic divorce or stressful event in their life, was honestly how much muscle mass they had. People with a good muscle mass have a tremendous amount of resilience going through difficulties. And it's like insurance, right? It's like this meat suit of insurance that we can build, and it will protect us because it has such a mitigating and modulating effect on our immune system, on our hormones, on our mitochondria, on all of the things. And so when life comes, because it will always come, that is a big factor. And I think another huge factor is stress load. I kept telling my husband during the early days of COVID, my friends who did not receive the intervention, I kept up with them, and I almost would quiz them, because as people came down with it, with the virus, I would say, like, how sick did you get? Because I wanted to know how my friends who were receiving the intervention versus not, I wanted to see how they were doing. And 9 times out of 10, the people who got really sick were, I'm talking non-intervention, they were all sleep deprived. They were all significantly sleep deprived and going through, whether they felt stressed or not, they were putting a lot of stress on their bodies for various reasons, whether it be a lot of travel, heavy workload, what have you. Stress and sleep deprivation are like monstrously devastating to people. And then literally like a week ago, I saw a study on folks, and they literally linked it up to sleep deprivation and severity of COVID outcomes. So like sleep's a huge factor. And talk about sleep and blood sugar regulation.
Oh gosh. So it's massive. I mean, sleep is very much up there with how much carbohydrate are you taking, how much insulin dose are you on, what's your body weight, what's your BMI, what's your waist circumference. Like there's factors. I mean, there's things even like humidity and the temperature and menstrual cycle status, but that's a big one. I would say there's kind of small factors that all influence blood glucose, stress, sleep. Anytime I do public speaking, you guys can see my CGM. It goes up, right? Anytime I'm sleep deprived, there's an arrow up. Like that's just what happens. It's just kind of the nature of it. So yeah, it's huge.
Yeah,
it's huge.
It's a big player. And just a few hours of sleep deprivation will start to put you in a more insulin resistant state. So
absolutely.
It's wild. Yeah. So yeah, let's go back to that just a second, because I want to make sure people really understand this. We're talking about type 1 diabetes over here so far as having to substitute the insulin because the pancreas is no longer making it because an autoimmune process has damaged the pancreas. And the carbohydrate load that the person's taking in and the sleep and the stress and all of those factors are variables. But then over here, we have this huge piece of the puzzle that I really want to emphasize, which is how sensitive are your cells to the insulin? And I know we talked about it, but I just want people to understand when we say you can go from type 1 to type 2, this is what we're talking about, because you could be doing everything right, but if you don't have good muscle mass, you're not exercising, you're not eating well, and you're not taking good care of yourself like I know you do, then you could be having this horrendous insulin resistance on this side. And so no matter how good you are about this stuff over here, then suddenly you're thrust in, and this is going to happen again as estrogen wanes. We are going to become more insulin resistant as we do, and the same thing happens to men as their testosterone starts to go down in middle age. So like this is a really important. Most of my audience, I think, is probably in that middle age category. This is a really important factor I want folks to take home, because that's just even more emphasis to and inspiration to like do the healthy things. Like you have to do all the healthy things, and it's a job, but it's a job we all have to do, whether we're type 1 diabetic or not. Like we all have to take our metabolic health very seriously in middle age.
Yeah. Yeah. If there's two things type 1s should worship, is Frederick Banting. He came up with insulin and your muscle mass. Like that's the second to insulin as to what's going to keep you healthy for a long life and have very few complications, if any. Like that's it right there.
I love it. I love it. That's so perfect. I think we should wrap it up with that, because I don't think there's a better emphasis that we could land on towards the end. Well, I so love talking to you, and I think we could do this for hours. You need to write a book, first of all. Please.
Okay, I'll get
write
on that.
the book, put it on Kindle, and get it out to the world, because I think your message is so important. And like you said, your community of type 1 diabetics has really been through the ringer, and hearing it from a fellow, warrior is probably the best message they're going to get. So it's going to be received the best, I should say. So do that. And then where can everybody find you?
Yeah, so you can find me on my website. That's probably one of the best places. I'm also on Instagram. And I have a really nice published article on type 1 diabetes. So if you head to my website, you can download that for free. It's a very nice integrative overview, kind of gives all of my researched ideas about the best way to manage type 1 diabetes. And you probably won't see that published many other places. So
I love it. What is your website for those listening?
It's drneville.com, and doctor is spelled out.
Okay. And how do you spell Neville?
Neville.
Okay. We'll make sure it's in the show notes for everyone listening. And you're on Instagram, and you often for the there's a lot of clinicians and healthcare professionals who listen to this podcast. So you do a lot of speaking too, don't you, at different conferences? I mean, I see you kind of all over.
Yeah. I'll be in Brazil in September. I'm all over the United States, though, throughout the year. So, yeah, absolutely.
Okay. So look out for Dr. Laura Neville if you guys are going to conferences, because it's a great lecture when you give it. So anyway, I love you, lady. I'm so glad you came on. Thank you for...
I love you too. Thank you.
Yeah, thanks for taking the time today.
Awesome. So good to be here. Bye, everyone.
Thanks for listening to the Dr. Tyna Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.